Hi, everyone. Welcome to another Monty Heart Lecture Series. It's a great pleasure to have today with us Dr. Gemma Figtree, who will be speaking about towards precision detection and treatment of coronary artery disease. She's joining us from Sydney, actually, so that's why the different time for the lecture, but it's a great pleasure to have her here today. Dr. Figtree is a professor in medicine and chair of the Multidisciplinary Cardiovascular Initiative at the University of Sydney and an interventional cardiologist at the Royal North Shore Hospital. She has an international track record across a diverse range of fundamental translation and implementation research areas and is recognized worldwide for her strategic leadership. Dr. Figtree leads a diverse team studying key mechanisms underlying susceptibility and response to a myocardial infarction, and she does interesting studies extending from the bench to large cohort studies and clinical trials. Discoveries from her lab have been published in leading journals, including Lancet, Circulation, JACC, European Heart Journal, with over 220 publications. Dr. Figtree is an investigator on grants over $42 million. She has been awarded 1 patent and 5 provisional patents and is the Chief Medical Officer for Procardia. She is a lead investigator and CMO of CAD Frontiers, a venture that pulls together an international team of clinicians, researchers, healthcare, and industry leaders into an effective platform combining discovery science, clinical trials, and commercial translation with a vision of a world without heart attacks. So she has received also numerous awards internationally and in Australia, and being named also as a member of the Order of Australia in 2023. So obviously very impressive CV, and we're very impressed by the wide range of studies that you do, and it's a really great honor to have you here. Thank you very much.
Thank you so much for the opportunity. I am really excited about being here today, and I will warn you, I do like to stir the pot a little bit to try to make us think about what things could be, how things could be done differently over the next 5 to 10 years. These are just some of my disclosures that Leandro's actually already mentioned. I also have an ear for the patient, which I think is an additional disclosure here. And in particular, we've been listening to these patients who develop pretty much standard atherosclerosis and heart attack, some of whom have, sudden cardiac death related to this, but who don't actually have any standard modifiable risk factors. And as you can see on the right, we've actually seen an increase in this in an area of Sydney where we actually do have really good prevention cardiology. So over the last decade, as we get better at identifying and treating the traditional risk factors, we're revealing all of the residual work that we need to be doing that's relevant not just for these individuals with no SMRFs, but also for those individuals who do have risk factors who need a better precision around how we actually prevent their heart attack. So history's really driven our approach to heart attack prevention, and the tools that we have obviously been fantastic, particularly at a population level, but it doesn't actually necessarily reflect the disease. Our challenge is actually really to try to identify and treat the underlying coronary plaque way before a heart attack. And I think we are just scratching the surface as how do we do this. In the past, I think we've been a bit scarred by surrogates. So we've been able to measure carotid plaque, for instance, but this is actually quite a different disease to coronary atherosclerosis, and I'll talk a little bit more about that. So these are 2 patients that have really inspired some of the work that we've done. Jen Tucker actually sits as the chair of the board now at CAD Frontiers. She suffered an acute coronary syndrome when she was 35, about 2 years after the birth of her second child. And this is Scott Kestevan. He is also a researcher actually, but suffered actually a cardiac arrest from plaque rupture. Neither of the individuals had standard risk factors. This individual, on the other hand, had the whole suite of risk factors, but does not have plaque in the coronary arteries. And so what is it that drives susceptibility and resilience to coronary artery disease? One of the other questions that we ask, actually in collaboration with Sydney's Taronga Zoo, is why chimpanzees don't get coronary atherosclerosis. They do get aortic atherosclerosis, but they, despite having an LDL of about 50% higher than what we see as our cutoff for in Australia. So sorry, I've got these in millimoles here, but you can compare it to what the Australian cutoff is. This is not associated with common atherosclerosis in the coronary artery. And so we are really fascinated about this. It's actually the humans that have become susceptible to putting the plaque and having this inflamed response in the coronaries. This is these are two of my fellows, Steve and also Sean, who coined the term Smurfless. And it's really pleasing to see that this has actually led to some focused work on these individuals that could help all patients with coronary disease. And this paper that we published in The Lancet a couple of years ago now, in collaboration with the Sweetheart cohort, showed that in up to over 60,000 STEMI patients, where this was their first time heart attack, you can see the blue line in terms of mortality at 30 days, particularly in women, was much higher than those that actually had traditional risk factors causing their plaque. Now, some of that may be the background medications that they came in on, but also we found that there was a lower rate of appropriate secondary prevention prescribed in that early phase as well. And so another fascinating observation that may contribute to the high mortality is there's about a 40% higher chance that the lesion that's the culprit is actually the LAD. And this again relates to the fact that biology is actually different in the LAD and the right coronary artery as well. That's actually been reproduced in a number of other studies since. Importantly, the mortality related to Smurfless STEMI is not associated with recurrent heart attack. This is within the first 30 days. It doesn't seem to be heart failure, stroke, major bleeding. It does seem to be an arrhythmic event, so sudden cardiac death. And we do wonder whether the heightened susceptibility and inflammation, despite a lower risk factor burden, may be putting these patients at risk of more peri-infarct inflammation as well. Fascinatingly, if you do live to 30 days, you actually do fine, although you can still see that, as with all heart attack patients, the outcome over the next 10 years is still not perfect, and we definitely need to continue to do better. This is some work that was led by Abdul here over in Perth. It's obviously a very small cohort, but it's focusing on the young STEMI cohort. And what you can see is that the hazard ratio here, where susceptibility becomes an even more significant issue, if you're young with no risk factors and you've got plaque that causes a heart attack, you've got a 5-fold higher rate of mortality in that first 30 days compared to someone that's age-matched STEMI. Fascinatingly, the plaque pretty much is the same, at least from an intravascular perspective. The baseline level of atheroma is slightly less. The percent with calcium on IVUS is slightly less, but ultimately that's pretty subtle. The higher mortality that we saw has been reproduced, and this is just a summary of some of that in a global meta-analysis performed predominantly by some colleagues in Singapore. Across the globe, the proportion of first-time heart attacks are probably more about 12 to 15%. But the mortality excess that we saw was seen again, and it's partially driven again by this lower guideline-directed medical therapies if a patient had no risk factors when they came in. We also worked with 2 separate large cohort studies that had, clinical trials combinations that had cardiac MR results. We again confirmed that the LAD was more likely to be the culprit. And what we saw is that the pre-PCI TIMI flow was less. The infarct size to myocardial salvage index, which is obviously not a perfect index, was slightly larger, but that again might be driven by the LAD. So we're advocating strongly for the fact that these individuals are not getting guideline-based treatment. But if you go back to the guidelines, they don't actually really exist as such. We have to assume that the treatments that we give to patients who have had a cardiac event with coronary atherosclerosis should be the same, but we don't actually know that. And it's very difficult to go back because most clinical trials don't actually report even the number of patients that have no Smurfs. And I think this is a really important group. So we really like to make sure that happens in the future. The analysis of 256 of the trials referenced in both the European and the US guidelines don't mention this, and obviously therefore can't no conclusions can be made. And it's actually very difficult to go back, as I said, to any clinical trials to do sub-analysis. And we reckon about 1.4 million people die worldwide of acute myocardial infarction with no standard modifiable risk factors. This is a paper that we published in JACC about a year ago now, and you can see the large number of international experts that have been very committed to coming on board with this. And obviously in these individuals, we need to think of some of the atypical risk factors that we do have evidence for, but we also want to start thinking about some of the things that we don't understand at all and are just beginning to scratch the surface at. So this is the clinic that we set up at North Shore. So if you're ever in Sydney, please swing by. And we're obviously trying to make sure that this is as widely available as possible using some remote and telehealth as well. Some of our work really coincided nicely with this paper that was published by the Global Cardiovascular Risk Consortium and presented last year at the ESC. Here they actually pooled and harmonised individual level data from 112 cohort studies in 34 countries. And you can see that 53 to 57% of cardiovascular disease events are explained by the standard modifiable risk factors. And this obviously needs to continue to push policymakers to do their best for heart attack prevention. But this is a lot less than the 90% that we saw in the InterHeart study back in early 2000. And I think this is partly to do with the study design, and it's also probably partly to do with changing environment and also improved primary prevention. But ultimately, a large proportion of cardiovascular disease remains unexplained. And as you can see, I wanted to start moving at an individual level to stopping doing the guessing and actually looking for, let's look early for the disease. It's really common, it causes a lot of death, and early detection of plaque would actually be a game changer. And it would allow access to effective treatments for all, including targeting the plaque itself beyond the risk factors. So hopefully some of you in the room might be interested in joining the effort. We have many individuals from around the world who are both academic as well as industry and also government. If you scan here, you will reach the website, which actually needs a bit of an update, but at least it'll connect you to us. These are some of the industry partners that have worked with us towards some government grants and also towards the mission. It's obviously ambitious and it's the kind of thing we can't do as individual institutes or programs. And the three cores of work that we focus on are the early detection of disease through novel biomarkers that we have a strategy towards. We also want to make sure that any marker that's actually associated with coronary plaque or has prognostic value can be tested prospectively in a more rapid way than we currently do. And also we've obviously got to focus on some of the kind of serendipitous findings of novel therapeutic pathways. One of the platforms that we have for discovering new markers to help us with early detection is the BioHeart resource. This has been embedded in the healthcare system, really run off the smell of an oily rag. We have about 4,000 patients enrolled so far, where they come in for clinically indicated cardiac CT, separate from an acute coronary syndrome, and they volunteer to be part of the study, obviously in an informed way. And we collect blood at the time, and that's very carefully dealt with in a way that I think is very much a unique asset. So we're not just looking at genomics and a few proteins floating around in the blood. We actually have a very biological approach to this and are particularly fascinated by the cellular components and also some of the membrane elements. One of the advantages compared to something like a larger cohort study, such as the UK Biobank, is the improved phenotyping that we get from imaging. This not only helps us bucket plaque into different subcategories, but it also can help us really clearly identify those that don't actually have plaque, which is very relevant for that resilient group. And when I say don't have plaque, obviously at a CT coronary level, but it's much better than just trusting the fact that the patient hasn't had a heart attack. The points of difference, BioHeart really focuses on the kind of membrane signaling and really trying to get as close as possible to the dysregulated elements involved in heart disease. So in addition to plasma and serum, where we have experts helping us with lipidomics, metabolomics, proteomics, and some other kind of more specific post-translational modifications, we're really interested in the PBMCs, which are quite hard work to obviously process at the time when you're doing it at large scale, but have been very, very valuable for RNA-seq, single cell mass cytometry, but also things like membrane lipidomics and also iPSC generation if needed. We also have experts on the genomics front, and a platform that is really designed to have best possible governance and security of the data for our collaborators to be able to begin to use in a way that has the best impact, but obviously really focuses on security of that data and ease of analysis within that platform. We're very excited to work with some amazing mathematicians. Jean Yang has been the lead for the last 5 years with us, setting up the design of the study and helping us achieve some of the difficulties around large omics data sets, and in particular removing some of the unwanted variation. And this paper is actually now available in Nature Communications. We are fascinated by individual omics, but also how do we actually integrate those together? And obviously, how do we focus on using that in a diagnostic fashion? And you can see some of this early effort. DMGV was an interesting one where we do see some increase in the odds ratio of having plaque detected if you went on to have a CT. You can also see when we combine some of these things, you do get an improvement of the AUC in terms of prediction compared to standard risk factors. This is pretty early days at the moment, although this paper was just published in collaboration with Peter Meikle, one of the world's lipidomic experts based down in Melbourne. And we found that there was a lipidomic signature that was significantly improved risk determination. What you see here in the pie graph is some of the challenges related to proteomics. We're using an MS-based approach, but as you know, there are a lot of different approaches that people use. Olink obviously being one, SomaScan another, and Protein Atlas being a kind of a way of using some of the mass spec data. But what you can see is that all of these only capture a small proportion of the proteins, and that's just those in the blood. Obviously, the proteins in the cells and the membranes all have different ability to be detected depending on how you do it. So we've got some exciting data, particularly in the Smurfless group on the proteomics that we can chat about later. Now, I don't know how many ticks you have in New York, but in Sydney, we actually have quite a few. And it's actually a global problem, I guess, of tick bites, not only in terms of the acute situation, but also what they can induce. And if a tick has recently eaten another mammal or had a meal on another mammal, it can induce this IgE sensitization to alpha-gal. And a group actually in Los Angeles published a small paper with intravascular imaging showing that if you were sensitized to alpha-gal with IgE, you were actually more likely to have vulnerable plaque features. We were able to take that back and look at it in our CT cohort in a much larger number of individuals. Sorry, this actual hazard ratio is slipped. This is about 2.5 times here, which is kind of important. And you can see here in the stemming cohort, if you actually have 20% of those with ST elevation infarct actually were sensitized to alpha-gal compared to 1.3% of those with no coronary disease. So these people are not sensitized in a way they actually get allergic kind of reactions to the meat, which can happen in some people with severe versions of this. But you can see it could be something that's actually an atypical factor from the environment that's contributing to plaque. So early days, and we're still working with immunologists to try to understand how we can better use this for risk identification, but also potentially for treatment, because there are ways of actually trying to reduce IgE sensitization. Does that actually improve plaque progression? Now, obviously, as clinicians, we really only have a CRP as something that reflects vascular inflammation and the underlying inflammatory component of plaque. But here you can see the single cell approaches to protein, and also you can do this obviously for RNA in PBMCs. And we can look at over 200 different immune subpopulations using the single cell proteomic approach. And you can see here just a couple of the different Treg signatures that we saw that were published just last year under Helen's first authorship. So I think, again, we're just showing you a snippet of what we're beginning to see, but this is, as cardiologists, we have a long way to catch up with our oncologists. We have the difficulty of not being able to poke a needle in a lot of this, but I think there's a lot more information in the blood that we can gain. Now, I actually did my original PhD and postdoc time in redox biology, and the caveoli are one of the most fascinating areas of interest for me. With over 250 different membrane proteins here, 80% of them are actually redox modified in a way, many of which is actually having functional effects in a way similar to phosphorylation. Now, we have a particular interest in the sodium-potassium ATPase pump, which is ubiquitously expressed in and key for obviously sodium, potassium, and calcium handling in the cell. It's actually glutathioneated with this reversible adduct, about 305 Dalton, that causes steric effects on the protein that inhibit its function, but are reversible in an enzymatic way. And we've discovered that we can actually measure this in red cell membranes in a way that reflects what's happening in the blood vessel and the heart. And so we're very much, we have a patent related to this and are interested in trying to actually see whether this could be a marker of caveolar redox stress that could be very important in cardiovascular disease. And here you can see just some of that early work done by one of my PhD students, where the correlation between what we saw in the erythrocyte membrane and the aorta in animal models was actually very close. Antibodies are a real problem for this kind of post-translational modification, and it's actually slowed us down a lot. But we're now working with neoaptamers and hope that this might actually solve the problem and make it scalable. We're also working with the single-cell RNA-seq data, again, trying to find signatures that could be more easily measured that actually predict plaque burden, plaque activity, or susceptibility or resilience to coronary artery disease, which are all things that we can look at given the CT data, as well as obviously clinical outcome. This is another angle that excites the biologist as well as the clinician in me. These are patient-derived endothelial progenitor cells that actually can be cultured very easily from the PBMCs. So they don't have the disadvantage of iPSCs where you lose some of the epigenetic modifications, and we can actually grow these spontaneously in up to 60% of the patients where we try. So we have a bank of about 500 different patients with these endothelial cells, and we found that particularly their mitochondrial function reflects what's happening in the coronaries. I'll skip through the chimpanzee side of things for the moment, but we're really looking for factors using the same protocol as our susceptibility and resilience in the humans to look at why chimps don't get coronary artery disease. This is just done in their routine health checks. We're not using them at all in any additional experimental approaches. Now, if you look up coronary artery disease biomarker, obviously you see a huge number of hits. What the challenge is how are we going to get these to patients so that we can pick up individuals like this that actually have early coronary disease and not just, I guess, give them some kind of probability score that's going to say you've got a heightened increased risk of heart attack. So this is where we've developed a different approach from a clinical pathway perspective. We're particularly interested in this group of under 60s. If you draw the line across the low, intermediate and high risk group, all the red dots are people that have got clinically actionable coronary disease on a CT who've not had symptoms. And you can see someone like Jen here who's sitting in her 30s with plaque that actually caused a life-threatening event. All of these people under the age of 60 who have that clinically actionable plaque are considered to be low risk. So how do we shift that and actually start looking for the plaque itself? So we've been working with polygenic risk scoring as an exemplar that we want to take other risk factors, other new diagnostic tricks through. We call it the Escalate model. And you can see here, many of you will know that polygenic risk scoring kind of suffers from this phenomenon where there's been many publications showing very strong prognostic value. A lot of the risk restratification, particularly in the intermediate risk group, doesn't necessarily look that exciting. It does significantly shift it a little bit, but the question is, how are we actually going to translate this? And so we've looked at this integrated approach where if you take the 1,000 people in the community who are going through primary care, who look like they're low or intermediate absolute risk, we do a polygenic risk score, and if they come up as the top 20% or top quintile, we actually go on and do a coronary calcium score study. And many people might argue, should we just go on and do a CT? Obviously, but at this point, from a screening perspective, calcium scores are, I guess, less controversial. And what we do is we then base the management off the plaque burden in a way that's evidence-based, and our aggressive risk factors goals are actually quite different. And this is kind of important when you think of some of the studies that look at risk restratification, because there's an assumption that if you're already on a statin, why does it matter? But actually, if you've got plaque that is a substantial burden that we know actually has a similar trajectory to events as if you've already had an event, so that's around about a calcium score of about 300, as shown by Matt Budoff's team, we actually know that getting your LDL right down to those secondary prevention guidelines is quite different to just treating the cholesterol from a primary prevention perspective. And so we also are then interested in, I'm shifting tack now to new drugs. And this is something that, as a biologist, I've been involved in for the last 2 decades. And you can see here, I guess, an exemplar of if you have a drug that can treat plaque activity and plaque vulnerability, it's very hard to think about how that would get translated. You obviously need funding and you need to incentivize some of the commercial aspects of this, but it is such a large exercise with this kind of massive disincentive of the large MACE-based trials at the end that things are being blocked right up at the early stage. So we're interested in the P2X7 receptor that you see here. It's fascinating because it's upstream of the NLRP3 inflammasome that then activates the release of interleukin-1 beta, but also a number of other cytokines, including IL-6 and 18. And what we found is that the receptor is expressed only in a small subset of the PBMCs, but the expression on those cells is actually associated with the degree of disease. And you can see here when you stimulate with extracellular ATP, which is actually something that happens in the setting of damaged tissue, you get this very strong release of IL-1 beta. And we've developed a series of drugs that actually can block that. And you can see that in patient-derived STEMI cells here. But if you want to take this through to humans, what do you actually need to do to accelerate that? And this, again, I think is where imaging can be helpful on 2 fronts. So this is a group that helped with the call to action back in 2022. We really believe that CT obviously measures the plaque biology. It is different to other surrogates we've used before, including the carotid. Postmortem histology shows very strong association with the imaging features that we see. And so we've led a consortium to try to bring together all of the amazing imaging scientists with the biologists and with also the industry folks and our government regulators. And so the FDA are actually very interested in this conversation. There is a massive unmet need from their perspective for us to find better ways of getting drugs to patients for coronary disease. And if you imagine cancer treatment development without imaging, we would be really stuck. And so I think we're in a situation where we actually need to slow things down a little bit to get some harmonisation around imaging of plaque to be able to use this. And I didn't really realise this until we started this initiative, that almost 50% of new drugs approved by the FDA are actually approved based on surrogates. And the renal guys have actually worked very closely together recently to have big success in this that you're probably aware of. And this is based on something that reflects the biology rather than, is the biology. And so we're very keen to work towards this. And I think the energy in the room from some of the early phase translation crew of different industry in pharma really have given us a sense that this is going to open up a lot of doors for new treatments to get through to patients that might be able to be given in a more precision-based way as we get better at categorizing different plaque types. So we want to reduce the cost, but not the rigor, and we want to obviously advance health of these individuals. In this process, we've really realised the importance of this harmonised approach, and these are just a scattering of some of the studies that have shown that non-calcified plaque volume is obviously associated with MACE risk. And this is quite difficult to measure routinely without automation, but automation is getting better, and combined kind of hybrid models are obviously very useful as well. And if you use this quite high cutoff that they derived, you can see that there's about an 8-fold hazard ratio compared to their compatriots. And this actually equates to about a 45% event rate over 5 years in this primary prevention population. So you can see that you could use non-calcified plaque volume or measures of plaque burden full stop to help enrich MACE-based studies, which is something that we're actually looking at to better articulate and better define. And then ultimately using serial CT studies for drug trials could dramatically reduce the study size down to more like 200 or 300 if we do it right. So we have to ask, does CT imaging reflect the causative pathway? Yes. Does the baseline measure relate or predict the clinical outcome? Yes. Does the change in the value reflect the change in the outcome? Now, we know from kind of statin-based trials and a few other drugs that have been tested in CT that there is an association. What we're working with at the moment with the consortium is to really make sure that we try to get those imaging-based trials actually embedded in the same MACE-based trial so that we actually get that association within the same study, and that could be dramatically change things for the FDA conversation. And ultimately, we want that difference to actually reflect the clinical benefit that we see of the treatment. And these are just some of the serial CT studies that demonstrate that the delta of the plaque progression or lack of progression actually reflects the clinical benefit of the drug. Kelly Branch from Washington is actually pulling together a really clever kind of meta-analysis of this at the moment with the help of Tom Green, who is the statistician who did a lot of the work for the renal surrogates. I mean, ultimately, if we can get this right, I think thinking again of how the cancer guys now see everyday practice, we will start seeing plaque in different ways, I believe. We all know you can have heavily calcified disease, much more, I guess, soft or non-calcified plaque with different attenuation features, different amounts of spotty calc or positive remodeling. But also, if we throw into this better molecular or precision approaches to plaque, we may be able to be much more precise with our translational approach to new drugs. Even just working with some of the companies that are trying to translate LP-Little-A-based drugs, it's quite difficult to kind of find the perfect patient population for these studies. And particularly if we want to do heart attack prevention, doing a primary prevention study with these new drugs is obviously prohibitive. We want to make sure primary prevention is not a second thought. But if we can identify patients that meet criteria for being suitable for these drugs, both from a plaque burden and a prognostic side of things, as well as from the mechanistic perspective, I think it's a much stronger situation that could really excite the field and see a different approach to coronary disease in the next 5 to 10 years. So this 3-step pathway for heart attack prevention is actually not as fanciful as we might think. Detecting and treating known risk factors is absolutely what we need to continue to do to reduce the risk of developing the plaque in the first place, and obviously to reduce the risk of progression of plaque if it has developed. But screening for coronary artery disease itself is something that we need to find better ways of doing so that we can identify and treat all patients with underlying ticking time bomb plaque. And ultimately, we want to then move to a situation of treating all coronary disease before a heart attack so that we can really see heart attack as that kind of catastrophic rare endpoint that we don't see very often. which might seem silly as an interventional cardiologist because it is my day job. But so ultimately, I think I've probably said most of this. I think precision opportunities with distinct phenotypes and specific pathways is something that could be feasible in the heart attack prevention toolkit in the future. The work that we're doing is really, I guess, it demonstrates the importance of collaboration with a diverse range of stakeholders, including obviously the patients themselves. And we're enjoying working with industry and with government, and ultimately to try to have a big vision that we need to attain. Thank you very much for your attention. I look forward to questions.
Thank you very much, Dr. Figtree. It's very inspirational, I think, the work you're doing, and very different. And so I want to congratulate you not only for the science part, but also the community base and the work you're doing, attracting different people working for the same goal. So please put your questions in the Q&A. So Daniel Lorenzat is one of our research fellows, and he's asking a question that is similar to what I was actually going to ask. So he says, great lecture. What do you think of pericoronary fat inflammation even before plaque development as a marker of high-risk phenotype?
Yeah, I mean, it's obviously very exciting, and I think plaque is something that we know, it's obviously earlier than a heart attack, but it's still fairly late in the stage. I think pragmatically, we obviously need to figure out how that would work in heart attack prevention land, and I think we're still going to need something that helps us get to, who gets imaging with contrast to achieve that measure. I mean, I actually, when I was in Oxford, was sitting next to, Tom Guccic was doing some of the early work before Harris came across, Harris Antoniadis, that's obviously the senior author on a lot of those, on the recent Lancet paper. But I know other groups are also working on this. I think one of the differences with how it was developed in the Oxford version is actually the biology, the actual fat from the coronaries of the patients that had imaging before their coronary artery bypass grafts was used to help derive the score. And I think that's actually probably helped some of the, this amazing prognostic ability of it to, to show, predict events and also to predict localized plaque. I think from the drug development perspective, it also has potential attractiveness that we still need to demonstrate, that it could be modified more quickly. And I think listening to the companies that are trying to develop drugs and de-risk the pathway for that, they definitely want to have a measure that ideally could be actually done in a 3-month window. And I think even with advanced imaging of non-calcified plaque, most of us are pretty skeptical that 3 months would be able to pick much up from a non-calcified plaque volume. Having said that, fat attenuation index from a biological perspective, could hold more promise on that front. One of the challenges, reason that non-calcified plaque volume was chosen for the group as the first effort is that we believe it is modifiable, just probably over longer time periods. We also think that it can be, I guess, measured in a more, I guess, across more different platforms and across greater number of sites. And I think it's probably a little less, I guess, controversial in some ways as to which approach you'd actually take it. So we're going to start with that at the moment, and I think the use of FAR in the future will be very very important, I think, both from a clinical perspective as well as also from a research perspective.
Yeah, no, I agree. Yeah, usually you see about 1 or 2 years, right, to see plaque regression when you look at sequential CCTAs, and that's what, right, you usually have to wait. The idea is with 5, you can wait a few months. That would be a game changer. I guess the question would be how much of that is a reliable change, how much, because the difference between high risk and not high risk is not that different, right? So the accuracy needs to be, I think, very high. That would be a difference. So when you talk about the different stages of disease, right? We're moving now to try to identify early disease to treat it. Do you see any differences in the way that that plaque can regress between early stages or late stages, or the value of imaging on this?
Yeah, I mean, it's interesting, isn't it? Because we haven't really had that opportunity. I mean, I suspect overlying this is there's obviously different phenotypes, full stop, of individuals. So when you see someone that's got a calcium score of 3,000, who's only, you know, a 60-year-old person, who's not been on any medication, who's not had an event, to actually get, we often think about the calcified disease as kind of the end stage, you know, effectively, you know, you've gone through this phase and you've then rapidly healed, and this is where you've gone. But why some people can get to a point of having calcium scores of 3,000 without having, and often also, interestingly, that first time they're captured as having plaque, never having been on a statin, with that low proportion of non-calcified plaque, or sometimes even none. I mean, my question about this is whether or not there's individuals with this phenotype have obviously got a different approach completely to those that get, you know, that when they have their non-calcified plaque volume, you know, they're more likely to actually have their event. And you see this in the cath lab as well. So this difference in healing stage, I think, is probably relevant to it. And you know, I think in terms of the question of obviously catching the plaque early, sometimes some individuals actually obviously only have very little plaque when they have their first event. And so overall, at a population level, we would definitely need to be catching it early, but catching any plaque is actually going to be useful for that individual's treatment.
Thank you. I think also that the rate of progression is very different, right? I mean, we're looking, even if we're doing CCTA and we're seeing the full phenotype, we don't know at what rate they will progress. We know the more plaque they have, the higher chances of progression. But we've seen, I mean, we published a case of a young kid that had calcium score of 0 and progressed very, very fast to triple vessel disease. So do you foresee repeating CTAs to see plaque progression, or more biomarker prediction?
I mean, obviously, if we could get a biomarker that reflect plaque activity in some way, which is not impossible. And I mean, part of the trouble is obviously designing the way you train these biomarkers to plaque activity or plaque progression, and getting the right design of the study to do that is something that we're very keen on doing. But say you had a marker of plaque kind of activity or progression, that would actually be able to help you figure out, you know, how to begin to try to achieve remission in that individual. And I think this concept of remission is really relevant to the patient who you're dealing with, particularly if compliance is an issue. But also, you know, we're currently using a regime that's obviously based off large populations, and there's opportunities to perhaps be more efficient with this. And I think we've seen that, you know, with cancer, you wouldn't want to give specific HER2-based treatments to patients that don't have that biological pathway from a breast cancer perspective. And so I think serial CT imaging to see whether or not the treatment you've got a patient on is actually achieving remission is not something that we see as appropriate in current clinical practice. But I mean, when I get a patient who's got some vague symptoms that suggest they might have progressed, and I sometimes might feel bad about doing a CT and it's a couple of years later because it's not guideline based, I then, you know, you go back and you see that the same patient may have had 5 or 6 other different imaging studies of other things. And, you know, I think we underutilize imaging at the moment. And I absolutely believe in, I guess, the rigor that we take this, but I think we should be a little bit more ambitious given this is actually the big killer.
I agree. Well, thank you very much. This was a wonderful lecture and very inspirational again. So let's please stay in touch, okay? And hopefully we can collaborate in the future.
I'd love that. Thanks, Leandro.
Thank you
Bye-bye,
very much.
everybody.
Bye-bye.